This is Peter J. Pollack, MD, with another Medical Practice Trends podcast, and our guest today is Dr. Stephen Schimpf, internist and former CEO of the University of Maryland Medical Center and author of The Future of Healthcare Delivery. Welcome, Steve.
Thanks for having me back again, Peter.
So our topic today is primary care, a non-sustainable business model. What do you mean by that?
Well, if you think about the primary care doc, and I'm a subspecialist, or was before I retired, so I'm not a primary care doc, but I've always thought of them as the essential backbone of our medical care system. And what we have in this country is about 30% of our docs are primary care docs, 70% are specialists. And this is just the reverse of just about every other developed country. But the reason I say it's a non-sustainable business model is really related to reimbursement. The things I'm going to discuss are not only related to primary care, but it's a good model for us to talk about. Reimbursement rates have been held down, if you will, by the insurers. I call it price controls. So the doc says, well, if I'm not earning any more money this year, yet my office expenses are going up, my malpractice expenses are going up, how am I going to pay those and still have a flat, at least, income for myself? And the way to do that, of course, is the old system that every business uses, which is make it up in volume. So the primary care physician has said, okay, I'll stop seeing my patients in the hospital. I'll stop going to see them in the emergency room. And that frees up some time for me so I can see a few more patients that way. And then the other thing I'll do, of course, is cut back the amount of time per patient. And that gives me a little bit more time. And so what most primary care physicians tell me is they feel like they're in a rat race. They're just in this proverbial wheel that goes round and round and round, and they can't jump off. Always seeing the expenses of their practice going up, but the income only going up if they can figure out a way to see, again, more patients. And so that's what I mean by a non-sustainable business model. That can't go on forever. It's gone for a while, and now we're beginning to see physicians say, like that movie, I won't take it anymore. I've got to find a way to get out. And some are getting out by retiring early. Some are getting out by saying, hey, I'll go work for the hospital. You can buy my practice or I'll just go work for you. And, of course, we know that medical students look around and they see the situation. They say, I don't think I want to do that, even if that might have otherwise been their preference. So we don't see new graduates coming into primary care. So that's the non-sustainable model that's there right now.
We seem to kind of go through cycles of this. I know a few years back when we had a lot of these managed care plans, there seemed to be a lot of people going to primary care because they were the gatekeepers and they were, especially in capitated plans. But as things kind of go in and out of favor, we kind of swing back towards maybe those types of systems aren't as efficient and aren't as cost effective. But it is true that in general, the system that we have here is fee-for-service, and people are looking at what am I getting for my work.
Well, that's right. And I think that physicians, all physicians, but we're talking about primary care right now, want to do a good job. They want their patients to do well, and they're generally compulsive people who pay a lot of time and attention. And yet, if you're seeing a large number of patients, you simply can't give the time that you would like for preventive care, for example, or for coordinating the care of those with chronic illness. To give a quick example of my own internist who switched, and we can talk about this in a few minutes, to the retainer-based approach. And he was telling me, after he'd been in the new approach for about a year, he said, it used to be if I had a patient who had a high cholesterol, I would just quickly write out a prescription for a statin and give it to them. Now I have a patient with high cholesterol. He said, we sit down and we start talking, and we talk about their diet and their exercise and their stress and their family situation. And he said, about 80% of the time, I can get their cholesterol down working with them without a drug.
Wow, that's great.
That's a huge difference. But he said I had to have the time available to be able to do it.
That's fascinating.
And, of course, that's reducing the cost of care, too.
Some people call this concierge medicine. So
yes,
there's an increasing trend of primary care physicians that are going into this. How exactly does that work?
Well, I think there's two things that are happening. One is some are just simply saying, Well, in both cases, I won't take insurance anymore, period. And some are saying, come and see me, and I'll just charge you fee for service, and we'll agree on a reasonable fee for the service. And then the other is the retainer base. So let's talk about the retainer base. The idea here is that the physician will reduce the number of patients they've been taking care of from, let's say, 1,500 or more down to 500. So now with 500 patients, they can give the time that they need to each patient. And usually they agree to the following. You can have my personal cell phone number, and you can call me 24/7. You have my personal email, and I'll respond to your email, maybe not within the next 10 minutes, but before the day is over, I'll get back to you on email. If you call and ask for an appointment in the office, I'll get you in within 24 hours, sooner if it's really urgent, but certainly within 24 hours. And I will go take care of you in the hospital, or at least visit you in the hospital, see you in the emergency room. I'll go visit you in the nursing home if necessary, maybe even do a house call. But all of this in return for a fee, a fixed fee of usually ranges between $1,500 and $2,000. Now, the downside of that is that you, the patient, just got to pay an extra $1,500 to $2,000 a year because you still need your insurance. Because if something else happens, you have to go see somebody else or go to the hospital, you'll still need your insurance. So you're paying for this, and it's an added expense. The other downside is that, let's say the doctor was taking care of 1,500 patients and now is taking care of 500. Well, that's 1,000 patients that are not being taken care of, at least by this physician anymore. And that raises some issues, particularly in a community that might not have all that many primary care docs. So those are some of the pros and some of the cons. The physicians that I have personally talked to, and it's about 10 of them now, who have made this switch, have said that in general it has worked extremely well for them, that it was a little painful making the switch because they had to say goodbye to some patients, patients they had taken care of for many years. And there was some anger on the part of some patients saying, you've kind of let me down by, I can't afford this or, whatever, or I don't want to afford it. So those are the downsides. But the upsides are, as one physician said to me, I'm working just as many hours as I ever did, but I know I'm giving better care because I'm spending the time with the patient, getting to know them better, and I'm doing the two things that are really important regard the first being preventive care, which we just talked about before, but the other being helping the patient who has a chronic illness coordinate that care. And just think of somebody like, say, with diabetes who needs to see perhaps 4 or 5 different physicians and a nutritionist, an exercise physiologist, and so on. And if the primary care physician sets all those appointments up or helps to set them up, number one, they happen faster. And number two, he's making a point of calling, like in an earlier one of our talks, I mentioned the otolaryngologist. He didn't just tell me to go see him. He called him and explained to him why he was sending me to him. Well, that made a big difference. The moment I walked in the door, the doctor said, "Oh, I know why you're here." And it was a much better relationship as a result. So that's the retainer base. The other, just straight out billing, what happens there is the same thing. Some patients will drop out, and the physician now has more time per patient. And that happened in the case of my wife's internist. She switched to it was called just fee for service, and she was able to give just much more time per visit, and as a result, the same thing, able to coordinate care, able to give much better preventive care. So both systems work, and each is a little different. And I think it's both a preference of the physician and preference of patients as to which is the better thing. But I think we can say with some assurity that this is going to be a trend that's going to pick up steam really quickly because the physicians are seeing that it works and the patients are hearing that it works. So it's a better system of care.
Good. Well, Steve, if someone wanted to get more information about this and your book, The Future of Healthcare Delivery, where can they get that?
They can go to Amazon.com or BarnesandNoble.com or to any bookstore. And if they'd like to see some excerpts first or see a video, they could look at my website, which is www.medicalmegatrends, all one word, medicalmegatrends.com.
Okay, well, thanks so much.
Thank you.